I wanted to ask our faculty a couple questions, remind you that you can use your devices to ask questions. We do have some case scenarios now where we're going to push them on their presentations and ask them how they would think about treating their patients. But let me start by asking Bruce, I'm intrigued by some of the potential therapeutic biomarkers you mentioned. What is it going to take for these to be validated? What do you think we need to do to show that they're reliable and useful? And when can we start applying them to practice?
Hello? Okay, now it's on. Well, first of all, it will take a lot of validation before these can actually be used in clinical practice because whereas, there's obviously a well-trod pathway for developing drugs, there's also an FDA regulatory rubric for approving tests and especially predictive biomarkers. And it is actually a very interesting challenge to develop a drug simultaneous with developing a predictive biomarker. Not easy to do, and actually in our field hasn't been done yet, although this has been accomplished in other fields like oncology. I don't see it happening too soon. There are a lot of candidates out there, but the one thing that I would caution you is it's not about developing one predictive biomarker for one class of agents or one drug. We're going to have maybe 6 or maybe 7 different mechanisms of action. So if we need to select the first drug for a patient, we'll need biomarkers for all those things to help identify in a competitive way which among these choices is the best one.
I've made the case before that while it's important we validate these, they don't need to be perfect. I mean, we're just looking for some clues here, for goodness sakes.
Yeah, another way of putting it is enrichment of the likelihood of responding.
Right. I think that's a great term. Tina, we talked a lot about, and we've spent more time thinking about moderate to severe inflammatory bowel disease, but a couple of people in the room asked questions about the mild Crohn's disease patient. This comes up often, and I thought you might comment on somebody who has just ileitis, minimally symptomatic, but symptomatic, and no other features of the disease, no fibrostenosis, no penetrating disease phenotype, and how would you approach that patient? This is always the challenge. And in fact, it's one of our case scenarios that we'll get to in a moment.
And, in truth, it's actually almost easier to manage a patient who has moderate to severe disease than a Crohn's patient with truly mild disease. And I think that one of the things that I look at in my practice is eliminating the mild to moderate and ask, are they mild or do they have moderate to severe disease? So one of the first things that I look at, especially in a patient who just has ileitis, is symptomatic but with mild disease, is, am I missing extent elsewhere? So looking at their labs, is their CBC normal? Do they have any iron deficiency? Is their calprotectin elevated beyond what I would expect for somebody who has just mild ileitis? And looking at that and making sure I'm not missing disease more proximally, which can be not necessarily captured on an MR enterography. But if you are talking about treatment, we have very little guidance. And even within our Crohn's disease guidelines, you really start with budesonide. And that's really one of the only agents that has any data to support induction for mild Crohn's disease. Now, the tricky thing is, what if they respond? What to use as maintenance? There's limited data maybe for sulfasalazine for maybe Crohn's colitis, but really not for 5-ASAs as a maintenance therapy for Crohn's disease. And this is where you really want to make sure that you risk stratify and prognosticate. So if they truly have mild disease, remember 60% do progress to moderate to severe disease, but 40% don't. So then you have to come up with your monitoring strategy. Oftentimes we don't necessarily put them on a maintenance treatment, but we do counsel about diet. We also counsel about avoiding other agents like NSAIDs, and then we do follow them routinely. You can't just stop following them because they're feeling better. Maybe checking an annual calprotectin, checking their labs to make sure that they don't develop an iron deficiency.
Someone in the audience asked about the commercially available serum test called Monitor. Is that something you've used in your practice, and can you tell the audience what it is if you are familiar with it?
So the Crohn's disease monitor is a relatively newish test that was that's available through Prometheus, and it uses a combination of serologies to determine whether or not a patient is responding to a treatment. I don't necessarily use that in my clinical practice. I'm very Asian, so I'm very cost conscious, and I try to use clinical intuition as well as objective assessments. I will say that I believe believe that their data for their validation study is in press in gastro. I think that we need a little bit more, I think it needs to be more fully validated before it's incorporated into our routine clinical practice, but I'd be curious to see what your thoughts are.
No, I think you've covered it. I would refer people who are interested in learning more to the in-press publication on this particular serum marker. It's a combination of 13 different markers of inflammation and mucosal integrity. So you can learn more about that, but I don't think we've been using it routinely in practice yet. Bruce, are all monoclonal antibodies equally safe in pregnancy?
That's a great question. We have, of course, much more data on the anti-TNFs, which we've been using for more than 20 years now. And these really do have an impressive body of evidence to suggest that they are safe in pregnancy. We have less data for vedolizumab, but what we have is reassuring. We have even less data for ustekinumab, although, of course, there are other disease populations using ustekinumab, but there too, in about, I think, 700 pregnancies that Uma Mahadevan reported in abstract form so far, it seems to be safe. But I wouldn't take that as a blanket statement that all immunoglobulins are safe in pregnancy. I don't think we can say that.
Okay. My last question for you before we do a couple case scenarios. Bruce, why does it appear that the newer monoclonal antibodies are less immunogenic than our old standby infliximab? What's changed in the way they're made or designed, or is it just good luck?
I can't really give you the specifics of how the manufacturing process may have changed to affect the immunogenicity, but I think that's only one of the possibilities. Another possibility is that it's really the anti-TNFs so far that really seem to have much more immunogenicity, and I just have to wonder whether mechanistically whatever vedolizumab is doing or ustekinumab is doing, that it may be sort of auto-suppressing the formation of antibodies. That would be another
That's interesting.
theory.
Okay, great. Well, keep your questions coming. We're going to go through a couple case scenarios that I think will prompt some additional discussion. So here's the first one. A 23-year-old woman with new Crohn's disease of the ileum and cecum, no perianal disease, a hemoglobin of 9 grams, responds to budesonide. So getting back to you, Tina, with what you were thinking. What would be your plan for maintenance, and how do you monitor this patient? So maybe you can wrap this up since you had started the discussion from the audience question.
So so there are a couple of clues. The first is that may suggest higher risk features. So she has a relatively young age at diagnosis. We don't know the extent of her disease involving the ileum and cecum, but she has actually a substantial anemia. We want to make sure that not all of it's contributed due to Crohn's disease. Maybe it's due to GYN-related issues, but if it is due to Crohn's and she responds to the budesonide, I would expect that her hemoglobin would also improve and stay stabilized with appropriate iron supplementation, usually with IV iron. And if they do respond, the plan for maintenance would be to actually assess for mucosal healing at least 6 to 9 months after completing the course of the budesonide. And if there's still disease activity, then moving on to another steroid-sparing agent. Budesonide is still a steroid, so recurrent courses of budesonide is not ideal. It's not meant as a maintenance therapy either. If we don't see any disease activity, the hemoglobin of 9 bothers me, and I would still counsel regarding how we're going to monitor, probably check calprotectins, follow their hemoglobin, and their other markers of inflammation if they were elevated at baseline.
So let me push you on this. What treatment would you use for maintenance? What are you going to do?
For maintenance, so, obviously it's a shared decision-making related question. We'd have to ask what are their plans for pregnancy in the future? What do we have their best data in terms of safety for that? What's our best data for bio-naive patients who, let's say her albumin's normal, her C-reactive protein's normal, she doesn't have any deep ulcers? I would feel comfortable giving her the options of vedolizumab, any of the injectable anti-TNFs. I wouldn't necessarily use ustekinumab first line, even though that's absolutely reasonable, only because in the state of California, I have difficulties achieving it first line and it would result in delays.
So Dr. Ha, yes, someday I'd like to have children, and I will defer to you. What should I be treated with?
And so, I think that given this is a new start, new diagnosis relatively early on, anti-TNF or vedolizumab are equally fine. If there's no other extraintestinal manifestations, I certainly think that vedolizumab is a reasonable first choice. If they're risk averse, I do think we have the best, probably the most consistent data for anti-TNFs. But in general, I would feel very comfortable using vedolizumab in this circumstance.
All right. Bruce, any additional comments before we go to next one?
No, I think Tina hit it perfectly.
Good. And I think that there are differences in insurance carriers and where we live regarding what treatment options we may have. We haven't run into the same challenges in using ustekinumab first line for some of our Crohn's patients, and I completely agree, of course. All right, here's our second case. A 30-year-old man with Crohn's disease with a penetrating phenotype. He had a prior resection 8 years ago when he was diagnosed. Now he has recurrence. Your colonoscopy shows a Rutgert's I3 and a single draining perianal fistula. He was treated with previous infliximab but had a loss of response despite empiric dose escalation. He's currently on prednisone. Bruce, how would you approach this patient?
Well, this patient is in trouble. Again, a young patient, already had a resection at a young age, really at the time of diagnosis, and also had previous loss of response to infliximab. We don't know if that's because of antibody formation or some other mechanism of having a low level or just not responding to this mechanism of action. And the patient has perianal fistulizing disease. For the perianal fistulas, still the best evidence is for anti-TNF. So if we're very convinced that infliximab really didn't work, and had adequate dose escalation, I would probably try a different anti-TNF, most likely adalimumab, probably in combination therapy with azathioprine or mercaptopurine at least for the first 6 months to a year. I probably would also do some monitoring of the drug levels to make sure that they're in adequate range, since he had prior loss of response to infliximab, and now this is a lifeline for him. I want to certainly get him off of the prednisone. I want to push the taper as much as possible. If you would consider other options for this patient, could the patient be on thiopurines alone? I think that's an older mode of treatment. It used to work for some patients, but this is a young man who is in the highest risk category for lymphoma. Is this patient going to be on that for years? I don't really love that. Could this patient be on vedolizumab? Sure, but the evidence for treating perianal fistulizing disease is not great. And for ustekinumab, there's also just a modicum of data to support healing of perianal fistulas.
So I just want to push you on this, because if he had been treated with the infliximab recently and had dose escalation, what's the rationale to try an injectable anti-TNF?
Simply because if we don't know, we don't know in this case whether he lost response because of anti-drug antibodies, but he may very well have. And simply, we may never know that unless we really want to try reintroducing infliximab, which we could also do and might get away with. And then if we did that, what I would do is at week 2, I'd be measuring anti-drug antibodies. And if they're very high, then we know we're going to stop. We should probably switch to adalimumab.
Okay.
So that would be another approach, perfectly reasonable, because after all, the best evidence for perianal fistulas is still infliximab.
So the timing of when he lost response and how much time has passed since that period of time might influence this too, which we've observed. The implication of the dynamic nature of the inflammatory pathways that might upregulate or downregulate. What about concomitant antibiotic when you're treating him with a new biological agent? Would you use one?
In the case of patients with perianal fistula, it is very important to make sure that you adequately treat the infectious part of the fistula. That means making sure that you probably do an MRI of the pelvis to understand the course and complexity of the fistula, make sure there's no abscess that you haven't missed and is not undrained. Also, an exam under anesthesia, probably to place a ceton, And there's good evidence to suggest that CTOM placement, as well as concurrent treatment with antibiotics in the setting of perianal fistula that you're about to treat, will assist in improving the rate of closure of the fistula over time.
Last question. Do you need to repeat a colonoscopy, or is a drainage of the fistula adequate assessment of his disease?
I personally do not believe that simply looking at the drainage of the fistula is going to be adequate. I think at some point, maybe 4 to 6 months down the road, I would be repeating the colonoscopy.
Okay, terrific. Thank you very much for that. All right, third case. 42-year-old woman with ulcerative pancolitis. She's obese and has plaque psoriasis. Her colitis is currently active. Her prior treatments were 5-ASA, steroids, and adalimumab, which did not work. What are her treatment options, and how would you assess treatment response? Tina?
Well, this is tricky because there's actually multiple factors that may actually impact the clearance. Whether or not you believe the data, having an increased BMI may impact the clearance of certain biologics. We don't know what her labs look like, but we're going to presume if she's failed multiple agents with active colitis, her C-reactive protein may be elevated and her albumin may be lower. In terms of dosing and anti-TNF, it's going to require quite a high dose, probably in combination and at a shortened interval. If she failed adalimumab, it'd be nice to know what her levels and antibodies were. If she had very high levels of antibodies, of adalimumab without antibodies, I don't know if I'd necessarily use infliximab. I think this is leading us to the question of ustekinumab versus tofacitinib. I think both are actually reasonable options, but for this 42-year-old woman, you'd have to really make sure that you clarify what their thromboembolic risk is. But remembering also that active ulcerative colitis is an increased risk for PEs and DVTs as well. So I'd probably err more towards the options of ustekinumab, tofacitinib, and she's really severe, potentially cyclosporin.
And Bruce, you want to add anything?
No, I think the plaque psoriasis sort of leans me a little bit more toward ustekinumab, although it could be that tofacitinib would work for that as well. It's not approved for psoriasis, but for psoriatic arthritis, however.
Tina, you made mention of the risk of thromboembolic complications with tofacitinib. How are you explaining that to your patients, and has it changed your treatment?
It hasn't necessarily changed my positioning per se. It's the same concepts that we use in any risk-benefit discussion with our patients. I do disclose that there may be a potential increased risk, but we also qualify that the study was in older RA patients with a cardiovascular risk and review some of the data, especially more recently published, looking at the risks of DVT and PE in our ulcerative colitis patients. It is actually a very effective agent. It can work quickly. It may take a little bit longer. So if it's the best agent, or a very good option to get them into remission. And I believe that the risk is really the greatest in the higher dosing. So you do have the option later on to decrease them to the 5 milligram twice daily dose, maybe the 11 milligram dose to see. But I don't think that it necessarily takes it off the table. It just, the discussion changes slightly.
Yeah, I haven't changed most of my patients, and we have a lot who are receiving 10 milligrams BID, but in part that's because it was a salvage therapy after they had worked their way through other treatment options. Last question related to this case. Tina, you start ustekinumab as your therapy. When do you reassess to know whether it's doing its job, and how would you do that?
So I'd certainly assess by week 12. I'd certainly want them to get the infusion in the first maintenance dose prior to switching agents, because prior to assessing for response, because you don't want to go through different MOAs too quickly, because we don't have an endless number of therapeutic choices. So certainly by week 12, I'd like to potentially check a calprotectin. If it was elevated previously, obviously their clinical symptoms matter, but if she's still symptomatic, I would probably do a sigmoidoscopy at that point to rule out infectious etiologies, see if there's any deltas, and then potentially change mechanisms.
Someone in the audience asked, does having psoriasis steer you away from anti-TNF? Let me ask the question a little differently. Does having psoriasis increase the likelihood you'll have a TNF-induced palmar plantar pustulosis or plaque psoriasis eruption?
I don't think so, and in fact we have to remember that actually anti-TNFs have been used as a pretty good treatment for psoriasis before even better things came along. So I'm not aware that having psoriasis predicts palmopustular psoriasis.
I don't think so either. It's interesting and very good question. All right, well, I'm going to end with this as a take-home message for you, and then we're going to do our 3 audience response, so please don't sneak away quite yet. The issue is, how do you incorporate this complicated maze of therapies into your practice? And we've heard beautifully from both our faculty presenters thinking about risk and trying to understand some general principles of the potential pathophysiology of IBD. And so we've adopted a treat-to-target strategy. You saw that Dr. Ha presented the CALM study, which is the evidence we have for it in Crohn's. There's ongoing efforts to study it in ulcerative colitis. But the principle is to do what many of you think you're doing already or may be doing in practice, which is choose your initial therapy based on risks of prognosis, poor outcomes, and how sick the patient is, the comorbid illnesses, and a variety of other factors. And very importantly, in an algorithmic fashion at some period of time thereafter, usually 3 to 6 months, reassess to obtain objective information whether or not you're controlling the disease. Now, that doesn't mean the patient should be sick and certainly shouldn't be getting worse during that period of time, of course, and we always say that to our patients. But doing this in a more algorithmic fashion moves you along so that you don't just wait for a complication. When the patient hasn't achieved whatever target it is that you've chosen, and we'll talk about what that might be in a moment, you can make adjustments. Most often it's an adjustment in the dose of the existing therapy. Sometimes it's adding a second agent, and rarely but importantly we cycle through to another treatment in our many options. And then you reassess. And you'll notice this goes in a circle. Very importantly though, if you adopt and you believe in a treat-to-target strategy, you must also adopt and believe in a monitoring strategy, meaning once you get to your target, you can't just push the patient out to sea and hope things go well. Remembering chronic diseases tend to drift away from control. The other thing to keep in mind, which Bruce highlighted, is that there are multiple inflammatory pathways that are at play here. What we think may happen is when you target one, another one becomes more dominant over time. At least that's the theory behind it. So keeping an eye on things and developing a monitoring strategy. Every patient in your practice should have a monitoring strategy, whether it's less intense or more intense is based on risk and their history. So what should your targets be? Well, traditionally we talk about them as a composite of patient-reported outcomes or symptoms with an endoscopic assessment. But there are many other targets that are relevant. It might be the patient's hemoglobin. It might be growth and development in a patient who is young and who's had a stunted growth or has delayed development. And that's obviously critically important in the younger patients. It may be findings you've had that correlate, whether it's by imaging, if you're in other places of the world, intestinal ultrasound, and maybe in the U.S. in the future, CRP, of course, calprotectin, or extraintestinal manifestations may end up being the target that you want to adjust therapy to control. And so the point here is that this needs to be as individualized as everything else we've ever talked about, but it gives you more of an algorithmic approach. And it's not that every patient needs to be perfect. We certainly acknowledge that can't happen, especially in milder patients. I was relieved and impressed to see that the Crohn's disease guidelines that were published by the ACG and that Bruce was one of the authors on suggested that for the low-risk patient with mild disease, a monitoring and watchful or symptomatic approach was one of the options. But the key to all of this and the takeaway message, I think, from the entire AIBD meeting for me has been that we've squarely moved into objective assessment of disease over time and a general principle of disease modification.